there's a lot of stigma attached to borderline personality disorder, and sometimes people are reticent to diagnose it. They think they're going to make people mad, or they're just going to label them and sort of alienate them potentially because once you've been called a borderline, like I remember this psychiatrist I used to work with. He was like, "Oh, that's right, just blame the patient. Like it's their fault that they have all these problems. You can't fix them with your pills." I thought, at the time I was like, "Oh my gosh," but hi.
Hi,
Um, so I'm Dustin Dippin. Nice to see you,
hi,
Lindsay.
I'm Lindsay. Nice,
Hi.
nice to meet you.
Um, mhm. And so, my idea with borderline personality disorder is to kind of destigmatize it, help people understand from a developmental perspective why this develops and what it means. I have kind of a stick that I go through with people about like a personality disorder is that you've developed a way of coping with stressors in your environment that's not really working for you. You're not getting your needs met. Our personality is something that we utilize to get our needs met in the world, to get that what we need in terms of relationships and basic sustenance. And when it's not working for us and it's a consistent pattern and you can sort of put it in a certain vein, we call it a certain type of personality disorder. Antisocial, histrionic, borderline is kind of a broad discussion. Borderline personality disorder was originally coined because it is the borderline between neurosis and psychosis. So people who, are anxious and depressed, neurotic, versus someone who hears voices or sort of detaches from reality, becomes very paranoid of others, can be a feature of that. And so borderline personality disorder can kind of contain a lot of those different symptoms. And so it's not uncommon when you're doing an evaluation for someone that likely is struggling with some degree of borderline personality disorder, when you go through your review of systems, they sort of have everything. They have some degree of bipolarity, ADHD, PTSD. Yes, sometimes they have some psychotic stuff. So they hear their voice being called, or when they're under stress, they feel like they're hearing voices in their head that may or may not be their own sort of internal monologue or critical voices that they've heard from childhood, trauma-based stuff. So I prepared a PowerPoint and I can go through it with you guys. Um, it's really just sort of the basics as though I would give it to, a psychiatry resident or a medical student. And if you have questions and you want to take the conversation in a different direction, that's totally cool. I'm not committed that I need to finish the slides on the PowerPoint. Also, if you have cases that you want to bring forward, I'm happy to discuss those specifically. I think more than anything, I just have a certain approach that I hope is empowering to people. I do want to just share this brief anecdote that I had the other day I think it was yesterday, with a provider in the community about an 18-year-old patient, because I think it helps to illustrate my point about how this can be empowering. So I had this, I guess I have to be careful about too much identifying information, but I'll say that I had an 18-year-old transgender person who came in who essentially had considered jumping off a bridge and had told their therapist in the outpatient setting that they were having this plan, and they made a safety plan. And then the next day, when they said they would not do this, they walked to the bridge and sat on the bridge and started texting with that provider that they didn't think they would actually die if they jumped off. And, it doesn't seem like that high. And then they stopped texting their provider. And so it was rather provocative. And this provider waited 20, 30 minutes, then called the police. The police found this person walking off the bridge and picked them up and took them to the ER for an evaluation. They ended up hospitalized, and that's where I met them. And I was talking to the provider, and I was like, okay, so what do you think's going on? And well, developmentally and da 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 da, and this and that, maybe autism, and certainly anxiety, depression, and struggling, worsening depression with the SI. I said, yeah, but like clearly this person was demonstrating some degree of manipulative behaviors. They're having some self-image instabilities. They are demonstrating reactive mood states. I kind of went through the criteria for borderline personality disorders. Like in some ways that sounds kind of sounds like BPD, And the person was like, well, yeah, but I wouldn't want to like label them, they're kind of young. And I was like, ugh. The goal of labeling someone with this disorder, like I said before, is to help them understand how they get better. The common teaching in good psychiatric management of borderline personality disorder is that 50% of people with good treatment will get better within 2 years. So for a lot of people, that's really informing them, hey, this is what you're doing. This is why it's not serving you. This is what you can do instead. These are the ways that you can get better. And if you follow this pattern, you will ideally stop doing some of the things you're doing that leads to you having this diagnosis. Sort of like Forrest Gump, who was famous in the movie for saying stupid is as stupid does, meaning that if you don't act stupid, you're not stupid. So if you have features of borderline personality disorder and you stop exhibiting those behaviors, you no longer have borderline personality disorder. It's not as though it's there forever and sort of deeply ingrained as a tumor in your brain. If you stop doing those things, you don't have it anymore. And so people are like, oh, she's just a borderline or he's just a borderline, whatever. It's like that's really not being very compassionate to the notion that you can help and educate these people so they don't do these things anymore. And so, reacting strongly to interpersonal stressors, which leads to suicidal ideation, non-suicidal behaviors, causing destruction of relationships, unstable self-image, chronic dysphoria, reactive mood states. And then there's lots of traits we could talk about. If you stop having that sort of reaction to stressors or other people, then you don't have borderline personality disorder anymore. And I think that can be really empowering to tell people. And what I'd love for you guys all to take away, and I'll try to say this later in this talk too, is talking to people about this in a compassionate way and giving them hope and a clear pathway to recovery for a lot of people is so empowering versus what we're afraid of, which is labeling them with stigma and disempowering them. Does that make sense? Okay. So does people have questions, reactions, thoughts, things they want to bring before I pull up a PowerPoint and start talking about that? No, nobody. Okay. Is this okay? Is it landing so far?
This is great. Thank you.
Okay, good.
And students, you better have questions.
How do I share my screen? Oh, I feel like an idiot all of a sudden.
There's down at the bottom.
Aha. I'm using a giant screen. Sorry.
Kylie and Lindsay, how are those chairs?
Is not everybody rocking their chairs?
Can you believe it?
So comfy.
So cool.
It's like I could spend all day here. I love it so much.
Good.
Can you guys see my thing now? Oh, Zoom system settings. No, hold on. Oh, Zoom. Gotcha. All right. Obviously, I don't do a lot of. Oh, I can't do it until I quit Zoom. Seriously? That's super lame. Wait, is it there now? We good?
Yeah, we're good.
Great. Here we go. So here is my not very refined PowerPoint. Feel free to jump in your questions. So we are going to review the criteria and how often it occurs. We're going to try to distinguish it from other common disorders like bipolar and PTSD. We're going to try to understand how this manifests in the biopsychosocial model. We're going to talk about evidence-based psychotherapies, and we're going to talk about rational medication strategies. I'll just say that I think one of the key things that I often say to people with BPD who say something like, I just need to get my meds right and that'll be fine. I just had this conversation today very strongly with someone. Medications are tools, they're supportive. The will of the human being is way stronger than almost any medication I could ever give you. So if, we can give you a medication to help stabilize your mood or to have better focus and engage coping strategies or to not feel so overwhelmed with anxiety or depression, but it will not fix this. This is not an issue that a pill fixes. So I often quote to people that 1 in 30 women and 1 in 50 men in the general population have borderline personality disorder. You could also say 1 to 2%, or even some people have said up to 3% of people in the general population have BPD or have had or have some degree of BPD in their lives. Like I said, you can get better, you can no longer have it. But that's pretty common. And so to be able to talk about this in a comfortable way that isn't triggering, that isn't labeling, that isn't creating further stigma is really important because the reality is, you know, in some ways, and of course I'm biased because I work at an inpatient unit, I have to pick and choose who I think it's most important to talk about BPD as their central issue because lots of people can have some degree of borderline personality disorder as a reaction to coping with early developmental trauma, unstable relationships. It's a way that human beings can develop in terms of the way that they interact with the stressors and they see themselves in the world around them. So just understanding that this is really, really common and it's not something to be scared of. And it's ideally something to sort of embrace wholeheartedly because it can be your bread and butter in psychiatry. And if you're comfortable with it, it can be sort of like a smooth transition to helping people, especially people who are really struggling, versus if you're uncomfortable with it, it could just be cringe every time you hit people with a severe form of this disorder and you think, why me? And can I transfer this person? And so I'd really encourage you to the best of your ability to get comfortable with this because as a psychiatric provider, it's going to be fairly prevalent. Up to 20% of psychiatric inpatients, I mean, I work on a unit where 75 to 80% of my people often have some degree of BPD. Often it can be diagnosed in females more often, but I think it is cultural to some degree. I mean, sometimes I'm running a case with someone, I'm like, wait, this guy has BPD. And it's just, it kind of shows up differently. And there's a masculine bias in the way that they talk about symptoms. And I'm like, so I even sometimes am like caught in this bias where I'm like, okay, I think, no, like these guys definitely have BPD. Um, High healthcare utilization, in and out of the ER, calling crisis, blowing up their therapist's phones, telling their psychiatrist they need to see them immediately, and then ghosting for an appointment, coming into an appointment and creating a lot of psychological distress in everyone around them. It can just be really stressful. And the issue, of course, is that there's a lot of self-harm behaviors, and sometimes people actually do end up ending their lives. Usually, people with BPD don't really wish to end their lives. They're trying to communicate their distress or try to take away their distress by cutting, and they're just trying to sleep. They're just trying to get some relief from their overwhelming mood dysregulation, and they just take too much one time, and it actually does kill them. But you'll see people frequently come in the ER who've taken a minor overdose, who cut themselves, who took an overdose and then vomited and then called the ambulance. And this causes a lot of functional impairment or sort of just lack of ability to do much of anything. Um, so you have to have at least five of these: fear of abandonment, unstable relationships, identity disturbance. I wouldn't say that impulsivity is typically one of them, but certainly there can be impulsive behaviors around self-harm or doing dangerous things like engaging in unsafe sex with new partners and doing drugs with them and a lot of stuff that's maybe fun to do when you're younger, but at some point most people start to move away from it. There's a really good book called The Buddha and the Borderline, and it's by someone with a really severe borderline personality disorder, and she at the end of the book is like, I'm better most of the time, but I still get caught up in my patterns. And she goes through all the therapies. It's such a good book for anyone who's looking for a primer, The Buddha and the Borderline. Um, Self-harm or suicidality, affective instability, mood dysregulation, chronic emptiness, that sense like, gosh, who am I? What do I have? What's even here? Intense anger, irritability, stress-related paranoia, dissociation. That's kind of where the intersection of the neurotic and the psychotic stuff comes in. And, a lot of these things you can kind of link. So, like someone who has unstable relationships, often they fear the relationship will end. This leads to, dangerous acting out, impulsive stuff, self-harm, a lot of dysregulated affects, and a fight or flight response starts to kick in. Oh my God, this relationship, oh, this always happens. So, you can paint a picture in which all these things are fairly interrelated. And when you're talking to somebody, you can get that sense like, oh, okay, you just said six of the eight things in telling me that story about what happened with you and your friend recently. And of course, we can all react this way. And so it's, having compassion and being able to relate to people in terms of feeling triggered, I think is just so important to not other them and to really try to make it like, yes, yes, we do this. We're humans. We do this. Now, someone might do it to the extreme and it really causes them to not be able to function in life. And that's where you want to help them. So emotional dysregulation, impulsive actions, decisions, self-harm stuff, making bad choices, interpersonal instability, not being able to maintain relationships, identity disturbance, just switching who you are, your perspective on life, your orientation, your value system, frequently realigning with new groups of people can be a part of that. And just to really characterize this in a certain way, if this is causing dysfunction in someone's life, it's called a disorder. But certainly people can switch who they are, be really moody, and switch friend groups. And as long as they continue to function at a reasonable level, we don't necessarily call it a disorder. So I think that's the thing to really help for us to understand and to help others to understand. The reason we're talking is because this isn't working for you. So going back to what I said, a personality disorder means the thing that you're trying to use to get your needs met in the world is not functioning for you. If you are emotionally dysregulated, impulsive, you have instability in your relationships, yet generally you function and you're likable and you are able to get through and maintain a job and housing and stuff, then you don't necessarily need to be diagnosed with the disorder. Now, you may benefit from working through DBT and creating some stability in these realms, but a disorder is you do not function because of these things. Is that clear as mud? Okay. Um, so Marshall Linehan, later she developed DBT. She wrote these books that are like impossible to read if you've ever tried. There's so many words and I don't even know how they line up, but she has BPD, had BPD. She worked through it. She figured out using a combination of Buddhism and her model that you could cure it, DBT, which is super intensive in terms of time and attention to people, and maybe isn't that practical for most of us who have a life outside of treating others. But Marshall Linehan was sort of the person that started to really push this narrative for a lot of people about what it means to validate people and be in touch with them and help them when they're in their crisis moments to move them beyond this sort of dysregulation, because she had this thing that we're all, these people are really suffering, kind of like the core tenets of Buddhism. We're all suffering and we're seeking enlightenment. Marshall Linehan was like, people who struggle with borderline personality disorder, they're coming to you and they want relief because of their struggle. And these are some tools you can offer them. Um, so uh, as I mentioned somewhat, childhood trauma is a massive risk factor for this. People who have early life attachment issues, the parenting issue, the parents weren't stable, substance use, trauma. Lauren and I are doing this project right now, talking about small T traumas and big T traumas. There's a book by Gabor Mate called The Myth of Normal, and he talks about small T traumas versus big T traumas. Small T traumas are emotional invalidation, not getting your needs met at a certain developmental stage, sort of the little things that you didn't get to grow and develop as a human emotionally. Big T traumas, you got blown up, you got raped, you got beat up, like awful, horrible events that sort of can cause PTSD. So developmental traumas can look different for different people. You may meet people who never had these massive, gross events in their life, yet had a cold and distant parent who wasn't present and didn't understand their needs. And they can still go on to develop BPD or histrionic personality disorder or any number of kind of things. And then genetic vulnerability. If your patient is sitting there talking to you about their mom, who quite evidently by their description seems to have BPD, then start to think about it. Not only were you raised by this person, but you share the same genetic pool with them, you may be more likely to react strongly to interpersonal stressors and have the associated symptoms. Um, Neurobiology. So, one of the things I often talk about, I just had this conversation with my last patient, was the idea that when you've had trauma, there's a part of your brain called the amygdala, the fear-based center, that is looking for danger. It is trying to keep you safe. You've been hurt before, and your amygdala is overactive, constantly vigilant about potential other dangers. And so in people that have had this trauma, they have often a reduced sort of soothing mother prefrontal region that says it's okay, it's going to be all right, don't worry, nothing's wrong here. And they have an overactive fear center, the oh shit amygdala, that's it's not okay. And so part of what we can do with our medications ideally is to try to help to tone up the regulation, the frontal lobe region. How do we help these people focus, engage coping strategies, and be calm in the present of danger and stressful situations, and also downregulate this fear-based response. And so, we can talk about what those types of medications look like. Serotonergic dysregulation. I'm not a huge fan of describing depression in terms of serotonin imbalances, but certainly serotonin plays a lot of role in mood. Interesting fun fact, in case you don't know this, there's more serotonin in our gut than in our brain. So there's a lot of somatic things that can come from serotonergic dysregulation. And in fact, you could argue that maybe more so than the effect in the brain or central nervous system. And then HPA axis, the basically the cortisol or adrenaline response, the hypothalamus, pituitary, adrenals, the stress response that we use to get out of bed and go do what we need to do can be really dysregulated in people with trauma, can lead to fight or flight responses to very small triggers and cause them a lot of overreaction and then fatigue, inability to sort of regulate. Jump in any point with your questions. I'll just keep going, but I feel like I'm just talking a lot. So things that often get confused with BPD, bipolar 2, PTSD, complex PTSD, ADHD, substance use disorders, or other personality disorders. Like I said, sometimes people feel like it's like impolite or rude to label someone as BPD. And so they find it's easier, more palatable to say that they have, panic disorder, generalized anxiety disorder, probably bipolar 2 or cyclothymia, and then certainly PTSD and maybe ADHD. And so when someone comes to you with the constellation of diagnoses like that, you have to question like, okay, is there a central theme here? And I'm not saying everyone that has these things has BPD, but I strongly encourage that you would start to look at the forest through the trees sort of thing. And one of the biggest differences between, I think this may be my next slide, but between bipolar and borderline personality disorder is that bipolar really has sustained mood shifts that last several days and are up then down or vice versa. Where, borderline personality disorder is often in response to interpersonal stressors, and they'll say, well, it's not like it lasts a few days, but like in the morning I can be like this, and then someone pisses me off, and in the afternoon I'm like that, or for 2 days I don't sleep and I'm just like out of my head, and then I crash really hard. And that's like more likely a trauma reaction or maybe a personality dysregulation. And so, not that it's always that way, but if you have a succinct 5 to 7 day periods of hypomania or mania with a prolonged depression following it, that's typically bipolar. Borderline personality disorder is more like up and down. And often when you ask them, it's because of some interpersonal stressor that they're dealing with. Um, Again, PTSD or complex PTSD, people can have severe trauma but not have the interpersonal difficulties and suicidality, non-suicidal self-harm behaviors. That they don't necessarily, people with PTSD or complex PTSD don't necessarily have the change in uh, self-image or associated with BPD. And then ADHD can be comorbid with like anything. It's, and you could have a whole lecture, of course, about neuroatypical sort of presentations, autism spectrum disorder, ADHD. But again, because ADHD has to do with executive dysfunction and the frontal lobe not helping to soothe as well in the setting of emotional dysregulation, it's not uncommon that people with severe ADHD can either have some of these traits or it can be comorbid, or it can look a lot like a personality disorder when someone is using substances or having a mood disorder in addition to their ADHD. Yeah. Um, so this is what I just said. BPD shifts shorter term, often triggered by relationships. Bipolar, not necessarily weeks, but I would say at least 5 to 7 days. Yeah, classically bipolar one, you can be manic for a month. Um, and of course, there's overlap. We made all of these things up. I'm very fond of saying this. Lauren knows I said this. There's no MRI or blood test for any of these disorders. We basically say, if the DSM says, here's some symptoms. If you have these symptoms, you have this disorder. And so it's up to us to decide what's most appropriate and help us to guide treatment. Unfortunately, we can't go get a CBC and be like, you have ADHD. It's right here, you see. It's and these screening scales are helpful, but again, it's all subjective report. Yeah. So with BPD and PTSD, you can have some overlap in terms of emotional dysregulation, dissociation. BPD, more of a pervasive relational instability and identity disturbance. I think that's what I said. Look at, we're tracking well. Um, Other things that you have to look out for, yeah, people get depressed, they have trauma. As a coping strategy, regulation, some people turn to either not eating or eating too much, binging and purging, using drugs to try to regulate themselves. And certainly anxiety, anticipation of what comes next can be a part of someone's experience when they're coping with this disorder. Um, it's important to take a good clinical interview. I have a very structured psychiatric review of systems I go through with people. It's kind of like casual in that hopefully everyone can understand my questions, but it's detailed enough where I can parse out. And then depending on what someone says, I'll definitely ask on, additional questions. So if someone with bipolar says, "Oh yeah, I get that," when I say my spiel, then I'll say, "Well, can you tell me more about that?" And that's usually when they'll go, "Well, you see, for 2 weeks, I buy cruises and spend all my husband's money, and I talk incessantly, and I feel like I don't need to sleep, and I'm baking pies all night long. And then I crash and I don't function for 3 weeks." Like, that's clearly bipolar disorder. Where someone says, "Well, yeah, I mean, if my sister calls me and pisses me off, then I don't sleep that night, and I'm yelling at everybody, and it's just my thoughts are racing. I like don't even need sleep, and all I do is like drink alcohol to calm myself." Like, that is more likely a personality disordered sort of interpersonal reaction. And so, getting information from other people, I often find it's very helpful to have a talk with family members or people that are involved in this person's care and try to explain to them what this is and how they can support them. I'm very fond of recommending books like I Hate You, Don't Leave Me, to kind of help people understand that push-pull dynamic of someone lashing out and trying to burn down the relationship, but also just hoping beyond hope that this person does not abandon them and walk away, even though they've sort of set fire to the bridge between them. And I think having those sorts of discussions with family members, not only to validate their experience, but to give them some tools and ways that they can research and understand what's going on with these people. So then when it hits them, they're not just caught flat-footed. And also for, people who are savvy, I'm fond of books like this, Stop Caretaking the Borderline or Narcissist, How to End the Drama. It has kind of like a step-by-step communication tool, like nonviolent communication, essentially. So how you can go about having a conversation with these sorts of people with these sorts of interpersonal triggers, ideally to trigger them less or not trigger them at all. And so kind of giving this information to families, gathering that collateral information, having a family meeting, I think, yep, go ahead.
What was the name of that book?
It's got a long title. It's called Stop Caretaking the Borderline or Narcissist, How to End the Drama. I can give you a list of books. Like, there's probably five. I won't
Okay.
overwhelm you, but The
Okay.
Buddha and the Borderline. Actually, it's right here. I didn't do this on purpose. I just keep them close at hand, people. I keep them close at hand. The Buddha and the Borderline. Um, and then I Hate You, Don't Leave Me is another good one. And then there's Borderline Personality Disorder Demystified. That's a good resource for patients, or excuse me, families. Um, yeah, I think that's a good place to start. You don't want to have too many books. It's better that you read some than just have a list of ones that you never read.
Yeah, thank you.
Yep. I don't use this tool as much, but there's the SKID 5 for personality disorders, which I think you incorporate in the screening tools, Lauren. Is that right? Yeah, I've seen
Yeah,
it.
I also have a bunch of copies of that at the office too, if anyone wants to ever look at them.
Yeah. And then a good suicide risk assessment. I do think there's an art to discussing suicidality, especially when you have kind of a chronic BPD patient, to sort of be like, "How's your mom?" And then like, "Oh yeah, my mom's okay, blah 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 blah. Good. Have you been having any thoughts about wanting to hurt yourself?" And well, like, yeah, if you just jump to like, do you have SI as like a way that this person is relating to you and potentially getting your care and attention, then that can cause this person to exaggerate or speak at length about their degree of suicidality, their plans, their intents around that. If you create a relationship with folks who have this disorder that's not based upon whether or not you think it's important they're suicidal, then that can validate other aspects of having a positive interpersonal relationship. And so I know that most of the people I work with BPD probably do have suicidal ideation all the time, or most of the time, or especially when triggered. My goal isn't to know that they have no SI. My goal is to amplify or accentuate other parts of their life that are also important and validating to them so they don't focus so much on those sorts of thoughts. And I would argue that that is, in some ways, the real crux of DBT, that we're going to give you an alternative coping strategy, something else to think about, rather than your thoughts of wanting to hurt yourself or end your life as an escape from your overwhelming emotional state. Um, and so while it's good to do a suicide risk assessment, have you done self-harm behaviors? How often? What's that look like? How lethal have these been? Do you